inconvenience, ma'am. Now I would like to invite Dr. C. Malleswari ma'am to come on to the dais and throw some light on surgical management of tubo-ovarian mass.
Is our dynamic and daring surgeon and gynecologist. She has completed her DGO and MS surgery at KMC. She is the product of KMC. And over to you, Malleswari. We are waiting for your presentation.
Welcome you all to my hometown Kabul. It is hosting the first National Foxy Conference. Thank you everyone. Thank you madam for introducing me. My topic of presentation for today is surgical management of tubo-ovarian mass. I will be dealing on these topics under these categories with introduction, etiology, clinical presentation, diagnosis, management, conclusion and references. Coming to incidence, common reproductive age group, up to 10% of women undergo some form of surgery in their lifetime for ovarian masses. Among the ovarian mass, 10% are of non-ovarian origin. Coming to the etiology, infections play a major part in tubo masses. Then comes neoplasm and ovarian. Among the infections, PIDs, endometriosis, neoplasms, cysts. Among the cysts, ovarian, para-ovarian, paratubal cysts. Coming to the neoplasms, benign or malignant. Coming to the benign ovarian category, these are most commonly functional cysts are the most common cysts. Next comes the endometriosis, serous and mucinous histadenomas, mature teratomas. Among the benign non-ovarian category, paratubal cysts, para-ovarian cysts, hydrosalpinx, tubo-ovarian abscess, peritoneal inclusion cysts and pseudocysts, appendicular and diverticular abscesses, pelvic kidney, some of retroperitoneal tumors can also present as non-ovarian causes of tubo-ovarian mass. Coming to primary malignant ovarian category, germ cell tumors, epithelial cell carcinomas, sexual tumors belong to the primary malignant ovarian category. Secondary malignant origin, predominantly from the breast and the gastrointestinal tract. I will be showing some of the pictures which are done at the hospital. This is the picture showing the hydrosalpinx with the uterine end blockage. These are the pictures showing the peritoneal inclusion cyst, which are presenting as tubo-ovarian mass. These are the pictures of broad ligament fibroid and twisted ovarian cyst. Then coming to the pictures, these are the pictures showing the para-ovarian cyst and paratubal cyst. These are the pictures showing endometriomas and appendicular abscess with mass and perforation with fecally presenting as a tubo-ovarian mass. These are the rare cases of surgical cases which are presenting as a tubo-ovarian mass as we are having a surgical center. This is a very rare case of GIST, gastrointestinal stromal tumor of ileum, which is presented with tubo-ovarian mass. And secondly, this is a picture of a momental cake. This is seen in cases of TB abdomen with ileocecal tuberculosis with momental cake. Next, I am showing the picture of peritoneal carcinomatosis with disseminated intra-abdominal malignancy which matted bowel loops, which also can present as tubo-ovarian mass. This is a rare case of scar endometriosis, which is presenting as a mass, and rarely a retroperitoneal sarcoma, which is presenting in the retroperitoneum, which is pushing the peritoneum and will be coming up to the peritoneum, parametrium, presenting as a tubo-ovarian mass. Then coming to the clinical presentations. So what are the clinical presentations with which a patient with tubo-ovarian mass comes to us? They usually come with pelvic pain, abnormal vaginal bleeding, palpable mass, fever or leukorrhea. So coming to the diagnosis, what is the role of history in examination in assessment of suspected ovarian masses? Thorough medical history should be taken with history regarding risk factors for ovarian malignancy, and we have to take a history, family history of ovarian and breast cancer. As breast cancers can also produce secondary ovarian tumors, Hugenberg tumors of the ovary. So thorough physical examination, abdominal and vaginal, should be done for every case, and this examination will give a clues for regarding the mass, tenderness, mobility, nodularity, ascites and local lymphadenopathy. The sensitivity of the physical examination itself in detection of the ovarian masses is around 15 to 51%. Coming to the investigations, what are the investigations we are going to apply for a case of TB ovarian mass? The most common investigation which we do for is CA125 levels. So these CA125 levels are not needed in all cases of premenopausal women. When the ultrasound is showing a simple ovarian cyst, it is raised in numerous conditions like fibroids, endometriosis, adenomyosis and pelvic infection. This is a marker of epithelial ovarian cancer and it is raised in 50%, only in 50% of early stage disease, and it has got more false positives and residual specificity. So values raised and less than 200 units needs further investigation. Values which are more than 200 units will be more diagnostic for malignancy. Serial monitoring may be helpful as rapidly raised levels are more important and associated with malignancy than high levels which remain static. Other investigations which we employ are lactate dehydrogenase, alpha-fetoprotein, HCG. This should be done in all women under 40 years of age with a complex ovarian mass because of the possibility of germ cell tumors. So what are the imaging modalities employed in assessment of suspected TB ovarian masses? The most common investigation is ultrasound followed by CT and MRI scan and lastly diagnostic laparoscopy. What is the role of ultrasound in the diagnosis of TB ovarian mass? Pelvic ultrasound is the single most effective way of evaluating ovarian mass, with transvaginal being more effective than transabdominal being more sensitive. I am going to give it certain rules which can classify ultrasonically whether this tumor is malignant or benign. IOTA group ultrasound rules to classify masses as benign or malignant. What are the B rules which indicate it as benign? These are unilocular cysts, presence of solid components where the largest solid component is less than 7 mm, presence of acoustic shadowing, smooth multinocular tumor with largest diameter less than 100 mm, no blood flow. These are the B rules, benign rules. And these are the M rules. Irregular solid tumor, ascites, at least 4 papillary projections, irregular multinocular solid tumor with largest diameter more than 100 mm with very strong blood flow. These are the things which we can diagnose even by ultrasound. Most probably we are doing mainly and we are depending only on the ultrasound because CT and MRI, with the CT and MRI cost we can do surgery. What is the role of use of CT and MRI? Routine use of CT and MRI for assessment of ovarian cancer masses do not improve the sensitivity and specificity. It is used to assess the peritoneal deposits, lymph nodal status. There is a calculation how to assess the risk of malignancy, that is RMI index. What is this RMI index? This combines 3 pre-surgical features, that is CA125 levels, menopausal status and ultrasound score. This is RMI is a product of ultrasound, menopausal status and CA125 level. Any level more than 200 is significant. RMI has a sensitivity of 78% and specificity of 87%. Combined approach, that is ultrasound, clinical and menopausal stages, will give a more conclusive thing for diagnosis of malignancy. What is the role of diagnostic laparoscopy? Is it preferred? It is preferred in deciding primary treatment in cases of advanced stage ovarian cancer. Diagnostic laparoscopy reduces suboptimal cytoreduction surgery in advanced disease and implementation of neoadjuvant chemotherapy followed by interval debulking surgery compared to primary debulking surgery. So these are some of the ultrasound pictures and CT pictures. What are the current guidelines in use for the management of premenopausal women with a pelvic mass? So there are certain guidelines like RCOG guidelines, Green Top guidelines, NICE guidelines, American ACOG guidelines and guidelines of Gynecologists of Canada. Guidelines which are suspicious of ovarian malignancy or CA125 level, ascites, first degree with breast or ovarian cancer. These are the pictures where I have done salpingectomy, removal of peritoneal inclusion cysts. These are the pictures showing the ectopic, multiple fibroids where each of can present as TB ovarian mass. Management of ovarian mass presumed to be benign in non-emergency situations. Asymptomatic women with simple ovarian cysts can be managed expectantly. Cysts that persist or increase in size are unlikely to be functional and need surgery. Cysts less than 5 mm need to be followed for 3 menstrual cycles. Usually they are physiological and they will resolve. Since more than 50 to 70 mm needs yearly follow-up. Larger surgical intervention should be considered. This is a case of mucinous hysterinoma, which is very large, 20 centimeters, but usually it's a benign. In laparoscopic approach better than the open surgery? Laparoscopic is associated with lower postoperative morbidity, shorter recovery time, early discharge, and return to work. In larger masses with solid ovarian tumors, laparotomy is appropriate. Should the ovarian cyst be aspirated? Aspiration of ovarian cyst, either vaginally or laparoscopy, is less effective and is associated with higher recurrence rates as high as 52 to 84%. These are some of the pictures of dermoid cysts which are operated laparoscopically. Is it important to avoid rupture? So all the time, because preoperative initial assessment cannot absolutely rule out malignancy by all the investigations seen in MRI, usually we need to have a tissue bag to avoid peritoneal spill of the cystic contents, bearing in mind the risk of malignancy. These are some of the complications of ovarian cysts we have faced: the torsion, rupture, hemorrhage, and gangrene. Coming to tubo-ovarian abscess, when not properly managed tubo-ovarian mass, it may lead to tubo-ovarian abscess. This is a picture showing the pus in the peritoneal cavity with multiple bilateral tubo-ovarian abscesses. So what is the treatment for tubo-ovarian abscess? It includes antibiotic therapy, mainly broad-spectrum intravenous antibiotics, and surgical approach is drainage of the abscess or laparotomy or laparoscopy. Depending upon the patient's condition, it is total abdominal hysterectomy with bilateral salpingo. These are the pictures showing the pelvic mass which contains the pus in the abdominal cavity. These are the pus flakes with frozen pelvis. So how then the malignant ovarian mass is managed? Surgical staging. Staging laparotomy is advocated in all cases of suspicion. It includes abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, peritoneal fluid sampling, and deposit sampling. So correct referral to a oncologist. Any suspicion of all these things should be referred to the oncologist for further management and evaluation. So chemotherapy. Depending upon the type of cancer, neoadjuvant or adjuvant chemotherapy can be advocated. This is a case of large ovarian tumor which is attached to the pelvis, cut in the pelvis, attached to the ileum, cecum, sigmoid colon, everything, frozen pelvis. There are certain specific scenarios. So in which scenarios you have to take precautions? Postmenopausal women, a new mass in case of postmenopausal women, especially with elevated CA125 levels, warrants a more aggressive approach due to higher risk of malignancy. In case of adolescents and young women, this is a picture showing a surgery of a laparoscopy done for an adolescent where fertility conservative surgery is more preferred than aggressive surgery because they are usually associated with endometriotic, benign cysts and tumors. Pregnant women. Treatment should be mostly conservative. This is a picture, the ultrasound picture showing 5 weeks pregnancy with a simple follicular cyst. But usually they are treated conservatively. The surgery is advocated only for cases with malignancy and torsion. These are the references. And these are always a team approach. With nurses, team of gynecologists, Dr. Malleswari, Dr. Jagruti, Dr. Prasanna, and surgeon team of surgeons, Dr. Chitibabu, Dr. Ramna, and my parents. Thank you all for your patient hearing.